Good afternoon, everyone. Thank you so much for joining today's webinar, Positively Safe, Addressing the Intersection of HIV and Domestic Violence. This presentation is supported through NASDAD's Ending the HIV Epidemic portfolio, which is funded by CDC PS 19-1906 Component A. My name is Maddie Helton. I'm a senior associate on the prevention team at NASDAD. I'd like to thank everyone for your flexibility today with our change of virtual venue to this Zoom call. Because we are on a call, I'd like to ask everyone to please make sure that your microphones are muted and remain so until the discussion portion at the end of this webinar. Please feel free to engage with the content using the chat function during the presentation. Also, as a reminder, this webinar is being recorded and will be made available on NASDAD's EAG website. This presentation is part of a series NASDAD is doing to highlight how social determinants of health impact our ability to end the HIV epidemic. While October was Domestic Violence Awareness Month, we are honored to welcome Ashley Sly today to keep this message going beyond October. So without further ado, I am happy to introduce Ashley Sly.
Thank you so much, Maddie. And hi, everyone. It's so nice to be here with you all today. I'm Ashley Sly. My pronouns are she, her, and hers, and I'm joining you all from Charleston, South Carolina. I am the Deputy Director from the Positively Safe team at the National Network to End Domestic Violence. And I've been at NNEDV for over 11 years now as part of the Positively Safe team since its inception in 2010. I've also worked on housing needs for victims, capacity building, as well as like implementing trauma-informed practices and voluntary services. So just a quick overview on who NNEDV is. We are a membership organization of the Domestic Violence and Dual Domestic Violence and Sexual Assault Coalitions in the 50 US states and 6 US territories. We 1990 as a policy shop and incorporated in 1995. In addition to our policy work, NNEDV has a variety of other projects that address capacity building, technology use and abuse, confidentiality, housing, and economic justice. And then our Women's Law Project provides plain language legal information as well as an email hotline. And our Domestic Violence Counts project, which is the other project that I manage, is a one-day count of survivors and their children and the unmet needs in each state and territory. So today we're going to talk about domestic violence, and then we'll move into the intersection and some promising practices and partnerships. So hopefully this begins to give you an understanding of the intersection here and those barriers that survivors face, and begin to some of those best practices and how to improve some programming to support survivors. So domestic violence is a pattern of power and control. It's not a one-time thing. It may or may not include physical abuse. And domestic violence affects people from all socioeconomic backgrounds across all races, ethnicities, and classes. People across the gender spectrum can be violence regardless of sexual orientation. Folks with high school diplomas all the way to PhDs and beyond can experience domestic violence as well. And perpetrators, they also come from all walks of life, again, regardless of race, class, socioeconomic status, education, religion, etc. So as I mentioned on the previous slide, domestic violence doesn't just impact women. 1 in 4 women and 1 in 10 men will experience domestic violence in their lifetime. Gay and bisexual men experience domestic violence at the same rate as women. However, over half of female homicide victims in the United States are killed by a current or former male intimate partner. So in 2019, the top 5 states for females murdered by males were Alaska, New Mexico, Nevada, New Hampshire, and Louisiana, with firearms being the most common weapon, handguns. So while domestic violence affects folks across the gender spectrum, we do know that most domestic and sexual violence is perpetrated by men. And laws and policies have really held up the patriarchy that allows violence against women to prosper. For example, marital rape was only outlawed in all states in 1993, Those last two states were Oklahoma and so not even 30 years ago. Some religious institutions also uphold those traditional roles of women, such as really seeing women only for the purpose of bearing children and managing the home. Other, institutional practices that prohibit women from holding leadership roles, and so on. So for many years, domestic violence was talked about as the cycle of violence. So a cyclical pattern of tension building, the explosion and violence period, and then the honeymoon period with it starting over again. However, this isn't exactly how domestic violence occurs. So it's not cyclical. Even if things, kind of seem like they're in a honeymoon phase and they seem okay on the surface, there's often a lot of other underlying tactics of abuse at play. So the power and control wheel seen here, this was created in partnership with survivors by the Domestic Abuse Intervention Project in Duluth, Minnesota. The outside of the wheel is physical and sexual violence, and these can fall into any of the spokes. And then the spokes are those different tactics an abusive partner may use. So coercion and threats, intimidation, emotional abuse, isolation, minimizing, denying and blaming, using children, using male privilege, and economic abuse. And there are multiple wheels out there, and you've probably maybe even seen some. The equality wheel is pretty well known and used at least across the domestic violence and sexual violence field, but I've seen it in other places as well. So the previous wheel uses she a lot. It's not really inclusive. However, there are, as I said, a variety of power control wheels, and this is just another one that was created for LGBTQ relationships. So it includes spokes on heterosexism, homophobia and biphobia, transphobia, and HIV-related abuse. And feel free to please pop any questions into the chat. I'll try and keep an eye on those. But Maddie, also please feel free to stop me at any time if there's a question that comes up that seems relevant to what we're talking about. So some of you may know someone, maybe a family member, a relative, friend, coworker, neighbor, somebody you think maybe is or was in a relationship where domestic violence occurred. And when you think about their situation, maybe even spoke to that person after they left, there were probably many reasons why they decided not to leave, or they can't leave if they're currently experiencing that. And those factors may include fear, so maybe fear of separation violence or child abuse, fear of death or a custody fight over children, immigration issues, even fear of calling the police. Those financial resources that create barriers. So the lack of, a job or employment, a lack of income, maybe a lack of credit. A lot of times survivors have had their credit, their abusive partner. Failure can also be another reason. So feeling like a failure for not keeping a relationship going. And kind of associated with that is maybe the pressure from family. So lack of support or anger towards them, not believing them. And also like not wanting to disappoint the family as well. There's always feelings for the abuser at play. So survivors, they still love their partner. They really just want the abuse to end. This feeling that it's my fault that the abuse is happening. Faith, so religious beliefs that don't allow for leaving a marriage. This belief that things will get better, so like a fantasy. Friends, so someone that's been isolated from them, they may not have anywhere to turn, especially if their families maybe cut them off as well. And then trauma, so that experience kind of creates barriers of not knowing the next steps to take. So the additional barriers, so poverty, kind of in relation to that financial component, identifying as LGBTQ, immigration status, housing access, particularly now, I think we're having lots of conversations about affordable housing and the lack thereof. which can definitely keep a survivor from accessing support. And to realize that often the most dangerous time for a survivor is while they're in that process of leaving the relationship or after they have left. So the abuser's violence tends to escalate as they're losing control over the victim. And survivors seek medical attention for injuries sustained as a consequence of domestic violence significantly more often after separation than while still living with an abusive partner. So about 70% of the visits to emergency rooms by women that have been abused occurred after separation. And another study showed that over a quarter of the women killed by their male partners were attempting to end the relationship when they were killed. I think it's also important to note that the studies have shown that survivors will attempt to leave an abusive partner between 7 or 8 times. So just being patient with survivors when you're working with them, they may decide to leave and then go back. There's so many things that hold them into that relationship. Again, the feelings for the abusive partner, that guilt piece, the financial piece, the lack of housing, a number of things are at play. But survivors face, just in addition to that increased potential for violence, the increase for the potential of homelessness, of poverty, of losing their children. And then of course, they're experiencing the stigma of experiencing domestic violence. So I briefly kind of touched on those power and control tactics, and we're going to talk a lot more about that in a little bit. But I also wanted to highlight the trauma of domestic violence and how this kind of impacts survivors. But trauma is the unique individual experience of an event or enduring condition in which the individual's ability to integrate their emotional experience is overwhelmed, or the individual experiences a threat to life, bodily integrity, or sanity. And I really like that because it is subjective. What is traumatic for one person may not be traumatic for another person. And trauma often shifts our understanding of the world around us, our sense of safety, our trust, our health, our ability to love others. But the way each person responds to trauma will be different based on numerous variables, coping skills, history of previous traumas. What do the support networks they have look like? Do they have experience seeking help? And if they do, how has that experience gone? Have they been met with a lot of resistance or been told that, you know, maybe they're lying about what has happened? Those experiences can really from accessing support and the help in the future. And then what are their experiences with oppression, particularly when accessing those social service fields? So experiencing domestic violence could lead to depression, anxiety, post-traumatic stress disorder, difficulty sleeping, excessive sleeping, memory problems, and much more. I just think of oftentimes we ask survivors to tell us their most traumatic experiences. And oftentimes we expect them to tell it to us in chronological order. So, you know, you may be working with a survivor and you may notice that a story really doesn't seem linear. Like the story may start at point A, jumps to point S, then back to D and E and on to point X, right? So the brain can also adjust memories as a coping mechanism. So while the memory is containing accuracies, it may not include the whole story or removes pieces to help the survivor. So just being patient with survivors because these things are impacting them. Their brain has been impacted by that trauma. So in addition to, experiencing depression and anxiety and the memory issues, it really has a dramatic impact on the body. So folks may have gastrointestinal issues such as IBS or acid reflux, respiratory issues such as asthma, cardiovascular issues. We've seen that those lead to heart attacks and stroke, along with other issues that a person may experience. So really impacting the entire body. And there's some great information with regards to reproductive health that is from Black Women's Blueprint that I highly recommend everyone check out as well. But really, long-term trauma has been shown to impact the immune system, body mass index, and the neurobiology of the brain, in addition to those other physiological changes. So thinking about how this might impact survivors living with HIV. And there are three common clusters of the body and brain's response to trauma. So experiencing all three of these could be a sign of PTSD, but they include hyperarousal. So this refers to the physiological changes that occur in the brains and bodies of trauma survivors, prepares them to respond to perceived dangers. So someone who seems easily agitated or always on the defense, they may be experiencing hyperarousal. These physical responses, they can occur weeks or months, even years after an event, when a person is reminded of the trauma. Avoidance, often our brain responds to stress by trying to keep us safe through ignoring or avoiding anything to the trauma. This can include numbing or feelings and thoughts connected with the traumatic situation. And these survivors, they may avoid therapy. I've heard advocates call them non-compliant or disinterested in services, but really, in fact, oftentimes they're just trying to avoid being re-traumatized. And then intrusion or re-experiencing events. These symptoms refer to the experience of trauma intruding upon your life after a traumatic event is over. This involves having memories of a disturbing event when you don't want to or weren't even thinking about it. This often makes people feel really like they aren't in control. This includes nightmares, flashbacks, panic attacks, other overwhelming feelings that survivors may have a hard time managing. And I think it's really important to note that people can experience the same but have very different responses. I was at Virginia Tech in 2009 during the shooting there. Went to school with a lot of folks at the same time. My husband and I both went to the same school. Very same trauma, but very different experiences, and our impact and our responses are incredibly different. So just keeping that in mind, you may be working with one survivor and they're demonstrating the signs of hyperarousal, and then the next, again, both experience domestic violence, but the next one is experiencing more of these intrusive thoughts. So keeping that in mind as we're working with folks. So let's talk a little bit about coping mechanisms. So here's the thing about coping mechanisms, especially when we talk about survivors of violence. Not only are people dealing with the trauma they're experiencing, but if a coping mechanism used maybe causes shame or fear or repercussions, survivors are oftentimes a lot less likely to tell an advocate and not receive the help that they need. I can't tell you how many times I've worked with programs who have prohibited drinking, turned people away who have mental health conditions, had very strict policies around drug use. But I always kind of bring it back to the point of, if someone had this perfect life, right, they wouldn't be seeking. We are here to provide non-judgmental help while also helping survivors work through their trauma and find ways to cope in a better way. So there's a list of all of these coping mechanisms here, but I include this picture of a woman painting because there are positive ways to cope. And as advocates, we can help them explore what are those positive ways that they can cope and maybe manage the trauma they've experienced. So before we move into the intersection piece, I just want to make sure if anyone has questions, y'all have a chance to ask those in the chat. So I'll give y'all a minute to go ahead and type them in if you want. All right, so no questions just yet, and that's okay. We will hopefully have some time at the end to answer any questions that maybe you come up with between now and then. So it's really impossible to talk about HIV without talking about domestic and sexual violence. Research illustrates that many women who are survivors of domestic violence are sexually abused current or past intimate partners, and forced unprotected sexual intercourse can increase a victim's risk of acquiring HIV. Forced sex leads to increased tearing and cuts. And since women are more likely to acquire HIV through sex than men, the forced sex greatly increases those chances. And it's been said that violence against women is both a cause and a consequence of the HIV epidemic. An understanding of and sensitivity to this intersection by both domestic violence programs and HIV programs can affect the physical and emotional safety and well-being of all service participants. So whichever provider is their initial point of accessing services. So we know that 55% of women living with HIV have experienced domestic violence. There's a 4-time greater risk in STIs, including HIV, as compared to women not experiencing domestic violence. 45% of women living with HIV experience physical abuse as a direct consequence of disclosing their HIV status. And there are higher rates of ART failure for cisgender and transgender women experiencing domestic violence. And you notice all of these talk about women. There's very little information out there with regards to domestic violence, men and transgender individuals. So that's why all these statistics are about women. But hopefully we're working on that, and there will be more studies that come out, and we'll have a lot more data to hold this up. So there's several ways in which violence and HIV are connected for women. Based on a study conducted out of the University of California, San Francisco, a majority of women living with HIV are survivors of multiple forms of abuse. Rates of PTSD, childhood sexual abuse, and IPV are particularly high among women living with HIV. Women who are abused or fear a violent response may not be comfortable asking their partner to use protection during sex. And similarly, women in abusive relationships may not be comfortable saying no to sex if their abusive partner refuses to use that protection when asked. And then we already mentioned the forced sex causes those cuts and scrapes and tears that can make it easier for HIV to enter the body, putting women at higher risk of acquiring HIV. And the fear of disclosing is still very real. So these headlines come from the Positive Women's Network and highlight 2 instances where a woman living with HIV disclosed and their partner murdered them. So working with survivors living with HIV, considering disclosure in like a safety plan could be a very important piece of the work that you do with them. And we'll talk more about safety planning in a bit. So I want to give you all a chance to participate, interact with me. So I just want you all to take some time, look at this list of ways that power and control is used. Think about tactics related to HIV specifically, and how HIV status may be used to control a survivor. So let's start with the one on the left, and y'all can chat in. Those tactics with regards to coercion and threats, privilege, emotional and psychological abuse, medical abuse, and isolation. And I think it's important to note that the abusive individual may be the one living with HIV, the victim may be living with HIV, or possibly they both could be living with HIV. Great, thanks, Nicole. Yes, hiding their medications, their ARTs, to point out. and not only hiding them, but potentially tampering with them. So, whatever way, exposing them to water, or disposing of half of them, or whatever. Multiple ways in which medication tends to be used as a weapon of control. Also applicable to birth control, absolutely. Threatening to disclose their status, blaming their partner for their HIV status, yes. And threatening to disclose, right? That can be in person to folks, to their employer. It could be virtually over social media. So multiple ways. Receiving a person's status, revealing a person's status as blackmail, threatening, threats or of HIV status, spiritually connecting sexuality to sin, trying to say that this is God's will, right? And then what about economic, spiritual? We touched on that one, spiritual, use of children, sexual, reproductive, and technology, other ones that folks want to chat in. Making them think no one else will care for them, right? So limiting access to funds for gas or travel to medical appointments and access to treatment, 100%. Controlling tech use. Yes, thanks, Nicole. So a lot of DV websites, if you've ever been, they have an exit button that'll to another site very quickly, because abusive partners oftentimes monitor the use of technology, whether that's checking histories or actually having like spyware on devices, keeping them from working or withholding funds, right? Taking resources that a person living with HIV may be receiving, like food, taking advantage of housing stability. Great. Perfect. Thank you all. Awesome. Well, I'll let y'all keep chatting in if you want to. And I did get a message with regards to if there's national programming, like to assist victims who cannot leave an abuser due to housing. So how would I say this? So there are federal programs. One is through the Office on Violence Against Women. They provide transitional housing funds to programs to provide housing for survivors, typically up to 24 months. Not every domestic violence program will have it, or homeless organization, but it's really important to ask and find out, particularly as we've seen an increase in funds from the Victims of Crime Act. A lot more domestic violence programs have been able to transitional housing, as well as when we've seen funds flow in from like the CARE Act over the past year. So definitely something to keep in mind. A lot of DV programs may have it, or they may know where to access it. In addition to that, a lot of homeless organizations are partnered with domestic violence organizations to provide rapid rehousing funds for survivors so they can access housing. And a lot of public housing authorities partners with domestic violence organizations. So access to public housing, Section 8 vouchers, things like that may be a possibility. Granted, that is all dependent on what kind of list your public housing authority has. I think in Charleston right now, it's a 2-year waiting list for housing through our PHA. So just something to keep in mind there. But domestic violence program is a really great place to start with regards to housing, because they know a lot about those programming specifics and know who to talk to, and they oftentimes know the good landlords to talk to versus the ones that are maybe shady, or that just don't upkeep their properties. So they're a great resource all around for domestic violence survivors. And that was a fantastic question, because housing is one of the hardest things to kind of deal with as a survivor. So y'all did great. Thank you for participating. So this is our DV and HIV power and control wheel. It is on our website in our Positively Safe Toolkit. So it has more specifics of those spokes that we were talking about. I think you guys hit on a lot of the major ones here. Whoops. Didn't mean to do that. Oh, privilege, I think, is one that people are kind of like, what does that mean? But using their the abusive partner's health status to guilt a victim into staying. So if the abusive partner is the one living with HIV, saying like, how could you not stay, or how could you not help someone who is sick? Or if the survivor is the one living with HIV, really claiming authority over those decisions. So you're sick, so I'm going to take care of this. Those kinds of things. So let's talk a little bit about promising practices. So after years of working with survivors in local programs, these are the principles that we've seen to be key in creating programming that really meets the needs of survivors, really as well as benefiting staff. So confidentiality or privacy of information, and we'll touch a little bit more about confidentiality in a bit, but very, very important with regards to domestic violence programming, and I'll explain why. But also that it's based on experiences in the field, so that we're listening to survivors, we're honoring their feedback and the lived experiences, and also reflecting on the work that we've done and continue doing. That we respect and honor the diversity and uniqueness of each individual, that our services will be totally voluntary. So not only is this a best practice for the domestic violence movement, it came from listening to survivors' experiences directly that were in our programs. So this actually became a federal requirement under the Family Violence Prevention and Services Act and the Violence Against Women Act. If you want more information on voluntary services, feel free to reach out. Happy to talk all about that. The things are also strength-based. So this means that we help victims find their strengths. We focus on these as a way of building confidence. So oftentimes abusive partners see the strengths in victims. They take advantage of those to basically flip that strength. So for instance, an abusive partner may be like, you just talk too much. Why do you have to talk to everyone? You're so nosy, or things like that. When in reality, that is seen as a really strong, a real strength for the survivor, that they're warm and inviting, that they have the ability to connect with other people. So being able to show a survivor how something that had been taken advantage of, that had been used against them, is actually a strength, is they're rebuilding their self-esteem. That things are client-centered as well, and trauma-informed. And then there's informed decision-making, so that all of those options are available to them, and what each of them is, and how to make that decision, what will happen maybe. So walking through them, but not making the decision for them. And then ensuring that our services are culturally resonant and culturally humble. In considering the promising practices, principles and criteria, we should be identifying areas that may hinder someone from accessing our services well. For example, experiencing fear on really a variety of things, right? These could be related to their own well-being, or the well-being of their partner or their children, or some other person that is close to them. And then services may be impossible to receive if a survivor doesn't have access to transportation or financial capabilities to even pay for that transportation. They have the technology capacity to seek services or information, again, especially if their abusive partner is monitoring their devices. So that's something to keep in mind as well. Like, how are you advertising that your services are available to folks? And then also considering if our programs are trans inclusive and affirming. Are we as service providers contributing to the discrimination of transgender and non-binary individuals and our policies and practices. Our services should serve to protect and support those most marginalized by society and work to really dismantle harmful systems of oppression. So are we creating spaces that understand and accept the challenges that people are experiencing, including the uses of substance, approaching our work from with a harm reduction model really helps to reduce stigma, people on their health needs, and ultimately prevents new HIV infections. So thinking about the way we're delivering. And I think I mentioned this earlier, but there's oftentimes some internalized stigma or concerns of being stigmatized by the services they seek, really demonstrating the need to ensure that our programs are inclusive and affirming and accessible, to really break barriers to services by dismantling stigma. So one of the most valuable, promising practices an HIV program could implement is, I don't really like the term screening necessarily, but really discussing domestic violence with all of those that are seeking services. This is just an opportunity for survivors to protect themselves, increase their safety, maybe receive referrals to programs that can assist them. But before any conversations, take some time to recognize your own beliefs and assumptions about domestic violence. So consider how those beliefs could impact the conversation you have. Victim blaming is a common occurrence in our culture, and this can really affect building any relationship of domestic violence or sexual assault. And honor the autonomy of the survivor, right? Don't recreate the power and control dynamics. The survivor likely had little to no control over anything in their life, and this is the time to give them back the control over their own decisions. Validate their experiences, conduct active listening and really confirming what they've told you. They've ability to make choices, but they've often just been dismissed and not been listened to. They've just want someone to hear them. So normalizing these discussions as well. Domestic violence may carry with it shame, guilt, embarrassment, and a survivor may not trust you enough to answer those questions you ask honestly. They may minimize or deny what is happening. So if you have the opportunity to meet with an individual more than once, it's important to ask those questions again, explaining that often individuals in an abusive or violent relationship may not always feel comfortable talking about what is happening, or fear for their safety if they do disclose, even if their abusive partner is nowhere around. Or just in general, they may not be ready to talk to you about it. But just keeping that door open and letting them know you are there to support them with whatever they could need if they ever do need these services or your support. So thinking about what are those different opportunities where a discussion could take place. So at intake or during counseling, if you're talking about sexual history, if whenever partners are discussed, that's another opportunity to bring up this conversation. So a lot throughout the work that we do with folks. And I'll say that best practice really would be that a client is seen alone. So in absolute privacy, the intimate partner should not be present. No parent, guardian, or adult, even a child really shouldn't be in the room with the client, because purposefully or unintentionally, information could be repeated to the perpetrator, or be someone who maybe inhibits the client's ability to speak freely and honestly. So accompanying individuals should be told that it's standard practice for a provider to meet alone with each client and be asked to remain in the waiting room. So if your state permits couples counseling, just pay attention to those nonverbal behaviors. Often behaviors may be an indication of an abusive relationship. So some kind of red flags. It would be like, does one for the other? Does one individual look to the other person before answering? Does a person appear to be more nervous in this setting? This could be like through fidgeting, looking down, remembering obviously that eye contact can be a cultural piece, and most people are nervous in these settings. Does the person just look scared or afraid? But if you feel like there's controlling behaviors or safety concerns, really, you have to decide what to do in each situation. Understanding your actions may jeopardize the victim's safety when the couples leave. This is an area to potentially discuss with a domestic violence program and how they can support you in this area. But it's hard because there's the possibility that after this, they're meeting with you, if they're receiving, say, HIV test together, that afterwards they go home and the abusive partner severely hurts the victim. So just things to really keep in mind as we're having those. If there's any opportunity to pull them apart, to be able to have those conversations in a trauma-informed manner, that's a great thing to do. And then every state has different laws or regulations. These really can be important to the conversation you're having, right? Laws, partner notification, testing restrictions, those kinds of things, but also knowing what your obligation is under mandatory reporting and duty to warn laws for your state. And before conversations, sometimes it can just be helpful to let the victim know up front what your obligations are. So they maybe have an idea of what they should or shouldn't tell you. But these laws do vary widely between states. So make sure check in with a lawyer on where your obligations stand. And then just remembering as well that some cultures are just more or less uncomfortable than others discussing topics such as sexual behavior. So considering what are some less direct questions that may solicit some information, but most importantly, I'd say just listen to the survivor, take their lead. And then I'd say, rather than rattling off a list of questions that feels a lot more like screening, I really just recommend that service providers and advocates should make the process conversational and view it as an opportunity to get to know the client as an individual, not as a collection of demographic information. All conversations should be an opportunity to build a relationship with the client. So whatever they disclose, to also ask them how you can best support them and remind them that you are here if their needs do change. And then everyone should be informed as to why they're being asked these questions. So what will happen to that information, and that they have the right to refuse to disclose any information. Important to not limit those questions to only certain groups. So not only to women or not only to younger folks, but remembering again that domestic violence occurs in all types of relationships. It affects folks from all different backgrounds. And then considering that language that you're using. Are victims of domestic violence and people living with HIV able to connect with it? So, and just having conversations over the work, so many people think that domestic violence is only physical violence, but in reality, it's so much more than that, right? Folks may not be able to see that what they're experiencing is domestic violence. So thinking about, instead of saying, are you experiencing domestic violence, considering saying something like, does your partner control who you see or where you go? Does your partner restrict access to money? Does your partner text you 100 times a day? Those kinds of things can really solicit a lot of information and get the conversation going. So what to do if disclosure happens? So if disclosure of domestic violence occurs, providing them with some helpful information and asking how you can support them, conducting safety planning, and then of course, a warm referral to a domestic violence organization. And then I think really the piece, particularly as we're thinking about the relationships we're building with our clients, is reassuring them that you're going to protect their confidentiality. Confidentiality is really a critical component of building trust with those that are accessing our services. So let's look a little bit deeper into these. And I mentioned safety plans multiple times now, so let's talk a little bit more specifically on that. But this is an action or actions the survivor can help lower risks in their relationships. Safety planning will be important for survivors living with HIV. It's important to note that a safety plan is developed by a survivor in partnership with an advocate. So each victim is the expert in their own life and knows what has kept them safe. As an advocate or practitioner, your role is to help guide them. In the midst of domestic violence, a survivor may not be able to think of all the things needed to stay safe. So this is an opportunity for you to make suggestions of things for them to consider. But again, ultimately, this is the survivor's plan. So they make the decisions. Let the survivor lead the conversation. And a safety plan really addresses what they need. So this means that the safety plan may or may not be written down. This could also mean that they want to document a couple of pieces, but maybe not most of it. They may also want a copy made of their plan so they can provide it to a friend or a family member, maybe a colleague. At the same time, they may not want you to have a copy of the plan. So remembering to listen to them. And a safety plan is a living plan. So when a victim comes back, or a survivor returns to you for services, just following up with them on that discussion and seeing if there's anything else they want to discuss or any kind of questions they have with regards to their safety and how you can support them. The plan may include, so for folks that maybe have 90-day supplies of medications, keeping maybe 30 days set aside in a hidden place could be helpful, especially if they need to flee pretty quickly. Making copies of important health records, as well as other important documents, a copy of a driver's license, passport, social security card, those kinds of things. Memorizing important phone numbers in case they do decide to flee. Some folks already have like a small bag pre-packed to grab in a hidden spot. If there are children in the relationship, so identifying not only a safe space in the home where the children can go, but also safe folks in the community if they need to flee. And if there are issues with the school, do you need to let the school know that whatever's happening, or that the abusive partner is not to pick up the kids, or things like that to keep in mind. A survivor may also want like a code word that they can use with you or maybe their family or friends, coworkers, in case they need someone else to be contacted. And then financially, right, because this is a huge challenge for survivors. They may need to open a bank account in their own name. And for some, they may not know how to do that. So if you have information or can refer them to someone, that's very helpful. But in terms of saving up money for survivors that don't work. So a survivor I had worked with, she was given a quote unquote allowance for groceries every week. And the abusive partner did check and requested the change. So what she would do, she would clip coupons, groceries, and then she would go back to the service counter and turn in the coupons, and they would give her cash back. So the receipt always showed the total, and she could provide that to her abusive partner, but then she had cash in her pocket that she could store aside for when she left. For someone that maybe is working and their job has direct deposit, and their HR department may be able to help them by creating a letter that says that their insurance premiums are going up, and that whatever that amount is, so it could be an extra $25 every paycheck, that survivor can ultimately funnel that into their own savings account. So things to kind of consider like that. And we touched on earlier the consequences of disclosure for victims. So it can be really important to help a survivor think through a disclosure plan if they response. So disclosing in a semi-public place, such as like a public park with many different people around it, but it's still private enough to have a conversation, but really public enough to get help if need be. And then they may also want someone to be nearby when they go, whether it's an advocate, a counselor, or a friend, just to know that the support is there. And again, if they need something, should something go wrong. Is asking what does survivor want in this situation, what would make them most comfortable, and how can you support them. So referrals, it's really important that when you refer a client to any of these services that it's meaningful. So not just handing someone a phone number to call, but providing the client or their survivor with the name of the person to speak with at the organization, or even offering to call them together. Giving the client or survivor an idea about what to expect from the referral. So for example, describing what the services are, what's available through that organization, what's kind of the realistic time frame. If you have to make an appointment, will it take 2 weeks to get an appointment, or can you see them within the next 24 hours? What does that look like? Who's the first person they're going to the door? Those kinds of simple things, particularly for folks dealing with trauma, can make the situation a little bit easier for them to manage. Asking the survivor if they need assistance with transport to the referral services. Oftentimes there are a number of barriers at play that prevent folks from seeking the services that they want or need. Transportation is a big one. So if you can help them access that transportation, whether it's through a bus pass or a taxi voucher or whatever, that can be very helpful. For folks where maybe English isn't their first language, knowing if that organization has translation services or bilingual advocate or support person. If they don't, is there another organization you could refer them to, or can you help find an interpreter for them? And then just follow up with the survivor, the client, to see how the services went. So it shouldn't just be a referral and then we're done, but often an ongoing conversation of how can I help strengthen the referral process and the service provision at the other organization. So one practice we have discussed fully yet is documentation. And this is often dictated by funders and government or regulatory agencies. So a few things to consider. Whatever is documented in the file should be directly related to your agency's purpose and services, and it should be objective information. So avoiding labels as a negative language, such as like dysfunctional, appropriate, maladaptive, anything that could be negative towards the person receiving services. So the file really should contain the problem and reasonable, measurable, time-focused goal plan that reflects your services. With regards to the liability piece, programs, at least domestic violence programs, they often receive court orders and subpoenas for contain a victim's information. The purpose of this is to find information in that file that can damage maybe a divorce or custody proceedings. So for this reason, we really encourage that we're thinking really clearly about how we're writing things and how this could be harmful to a survivor. And then when partnering with domestic violence organization, really should talk about documentation policies together and understand the confidentiality protections of each other. So domestic violence programs have very strong confidentiality restrictions under the Violence Against Women Act, the Family Violence Prevention and Services Act, and the Victims of Crime Act. They are legally barred from releasing any victim information without a time-limited specific release of information, unless a law mandates disclosure of information, such as a court order or mandatory reporting. So very important to understand. Often organizations want information from DV programs and they legally just cannot disclose it. So you've probably heard the term, I cannot confirm nor deny, and you will hear it a lot from domestic violence programs. So we have 30 minutes left, and I just want to spend this little bit of time talking about collaboration and building the because I think they're just a very important piece of actually supporting the folks that we're working with. And collaboration helps build our knowledge base. The more knowledge you possess and resources you're aware of, the more you'll be able to help your clients. Collaboration results in those appropriate referrals. So when you're collaborating with other professionals and understand their programs and services, you're able to make more appropriate referrals when needed. Really focusing on a holistic approach to meeting the client needs with better and more efficient access to a range of services, seeing improved quality and consistency of services and really a greater responsiveness to the needs. And then saving time. When you make those right referrals, it saves time and it's a win-win situation for everyone involved. When professionals collaborate, they can reach more people, as they will know exactly where to send those folks to meet those specific needs. And then just respecting expertise. So calling on other community organizations that are well-versed in the issue at hand to best support the needs of those seeking services instead of trying to do everything. And really, it's becoming increasingly difficult to accomplish, right, our organization's tasks and goals with such limited resources, especially right as we're in this time of economic difficulty. So collaboration helps agencies share expertise to make appropriate referrals, to avoid the duplication of services and save money and ensure that seamless system of service delivery. So some ways your organizations could partner could include your organization may invite a domestic violence organization to do a presentation on DV, and the DV program may invite the HIV organization to do a presentation on HIV. Presenting, you could, presentations could be both for staff and for maybe clients at the respective program. For HIV programs, working with DV programs, I think it's really important to include some information on PrEP and PEP. Many DV advocates have little to no knowledge about either of these, and survivors could really benefit from this information. Program staff could have site visits to better gain understanding of the services the other program offers, so they have a better idea of when they're making those referrals, what to expect. Potentially joining forces to visit other organizations working on anti-violence issues or women's issues, health issues, potentially going to schools together to do presentations, sharing materials, including condoms and lube. I know some programs, particularly around funding, do require memorandums of understanding, and these are very just helpful to outline what your partnership looks like, and ensures each program can follow through on the actions to which they've committed themselves. So if you are looking for an MOU template, we do have one in our toolkit as well. And then a few other ways. So oftentimes domestic violence organizations have or participate in what's called a coordinated community response. So there's the possibility of including an HIV service provider as a partner on the CCR. Potentially offering on-site HIV testing. So this could occur at a domestic violence public office or administrative office. And this is just an opportunity to not only have folks from the tested, but giving the opportunity to invite survivors to be tested as well. One thing that I've seen work, I think, really well is creating space for a domestic violence advocate at an HIV organization. And this could be, they could be in office on a weekly or biweekly basis, just so you know when you're working with survivors that you can tell them that, this advocate from the DV program will be here every Thursday or every other Thursday to talk to someone, and they're not ready to go directly to the DV program. They know they can access that support there. So lastly, I just want to touch on including survivors and people living with HIV as partners in our work. Meaningful engagement is person-centered, is really a person-centered approach to encourage and invite folks to purposefully contribute and participate while not diminishing their expertise because of, say, a lack of educational degree or training. And supported decision-making is a respectful and responsive method of allowing people closest to the problem to keep their rights and decision-making capability, and to communicate their choices free of judgment and stigma. Survivors and people living with HIV bring meaningful expertise and experience. So their involvement in our partnerships and programming really works to strengthen the work that we do and the services that we offer. This is really an opportunity to build leadership and help cultivate those skills among folks that may be accessing our services. And by meaningfully involving survivors and people living with HIV, we should be giving them the opportunity to be honest with us. So what we want is honesty, because this ultimately helps to build our services in a survivor client-centered manner. And really gathering that truth, feedback from them can look, could appear in different ways. I know a lot of firms do like focus groups where their survivors are able to gather a lot of information and provide it as direct feedback. That way, one person isn't like singled out or, fears any kind of repercussions, but it is a group, not consensus, but collaboration where they can develop this stuff to bring forth. But it's also really important to consider the voices that we're listening to and receiving feedback from. So if you are not hearing from diverse group of survivors and people living with HIV, asking really why that is. Are you including voices of sex workers, people using drugs, transgender and gender non-binary folks? Diverse voices only help strengthen our programming, not hurt it. So their meaningful involvement will greatly benefit your organization. So that is my content, but I wanted to leave some time for questions and any discussion folks want to have, whether you want to chat it in. I'm also okay, Maddie, if people want to ask directly as well. And I'll give you all a few more minutes to think about it. I know kind of just processing everything we went through and thinking about how it really, impacts the work that you all do, could be challenging in the moment. So it seems like there are no questions. If y'all come up with any, oh, here we have one. How can local health departments collaborate with domestic violence organizations? Great question. I think there's a number of ways, especially if there's no HIV organization in the community, a lot of health departments will send out like a public health nurse to do the partnership and be able to provide the testing for survivors. I think with COVID, I think there's a lot of ways to be collaborating and providing support around that, access to masking, information about vaccinations, things like that can be really helpful. I think in general, just helping DV programs know where they can turn for health advice as well, because oftentimes they're not versed in those things, and health issues could come up, and just not knowing what they need to do to support a survivor. Even though we don't recommend that survivors be required to disclose any of those health issues, they often do come up, and programs are like, what does this mean for us? How do we handle this? So just having that support is I think important. Thanks, Mary. Yeah. Oftentimes it's not there. We're not seeing a lot of HIV organizations screening for intimate partner violence. Some are, but maybe not doing it consistently as well. So that's a challenge we run into, is folks feel like they are only confident in talking about it sometimes, or maybe that they're working with. So helping people really build the knowledge and skills to be able to have that conversation consistently, I think is important. And we do a lot more training and whatnot about having those conversations and what does it look like. So happy to chat with others if that's something y'all are interested in down the line. But yeah, I think it's important that we implement this consistently, so folks that need it are able to access the support they need. Well, thank you all. I really do, appreciate you all taking the time out to be here with me this afternoon. If any questions come up, please feel free to reach out to me. This is my email. You can also send one to my team. It's myself and my colleague, Robin, and one of us will be able to get back to you. And the link for the toolkit is there as well. So back over to you, Maddie.
Thank you so much. So as we close out today's webinar, I would like to thank our phenomenal speaker from the National Network to End Domestic Violence, Ashley Sly, for her time today and the incredible work that both she and NNEDV does. Thank you also to my colleague Krupa for the support she provided during the webinar, giving people access and helping to monitor the chat. I'd also like to remind everyone that NASDAD provides technical assistance on EHE implementation, and health departments can access TA by contacting NASDAD directly or through CDC's SIBA tracking system. I know that I speak for Ashley and the entire team at NASDAD when I say thank you so much for your time and attention and for spending part of your day with us. Please feel free to reach out to us anytime with questions or to continue the conversation that we started here today. Thank you, everyone. We hope you have a wonderful remainder of your day.